Good afternoon, everybody. Good day. Okay. This is our second lecture. Let me just share my screen. So the topic is a very long topic. Overview of substance use disorders and other forms of addiction, which actually I'm not going to discuss anymore. We'll just talk about it a little. I'll just send you some slides for that because the overview of substance use disorders is quite a long topic. We'll focus on disorders themselves and not the management. Okay, quiz time. What is the title of the TV series about crystal meth? So it's Breaking Bad. Okay. Through what route is meth eliminated? May sagot na pala. Yung slide ko ganun. Hindi. Urine, okay. So before we talk about all of the substance use disorders, we have to talk about the reward pathway, right? Because it's one of the core issues on like why people take substances in the first place. Right? So why do people take drugs in the first place? So they say to feel good, to have novel feelings, sensations, experiences, and to share them, and to feel better, to lessen anxiety, worries, fear, depression, and hopelessness. So these are the brain circuits that are affected by drug abuse, and addiction. The areas here contain circuits that underlie feelings of reward, learning, and memory. No? So each of these brain areas and the behavior they control must be considered when developing strategies to treat drug addiction. So we have the prefrontal cortex, the anterior cingulate gyrus, the orbitofrontal cortex, right? The subcallosal cortex, the nucleus accumbens, the ventral pallidum, the hippocampus, and the amygdala. Okay. It's the dopaminergic pathways and the serotonergic pathways that are involved, right? Mainly when we talk about the reward pathway. Okay, so normal reward. So when you do something pleasurable like eat or like have sex or drink or like do rewarding activities, merong reinforcement o there's a release of dopamine. That's what gives you the pleasurable feeling. Okay, but also that could also be induced by taking in certain kinds of substances. Okay, and then the what do you call that, the dopamine release is like much more than like the usual activities. So mas maganda yung pakiramdam pag ganon. And like hinahanap, no? We look for that feeling. We want that feeling to happen again and again. Nagkakaroon ng parang napo-program tayo. We want that happening again and again. Okay? And so there's involvement of other factors as well. Okay? When we talk about addiction. So these are the list of substance use disorders in the DSM-5. Now the DSM-5-TR actually. No? This is the list. So we're actually going to go through them as fast as we can, I think. I think like I have like almost 200 slides here, but like we'll try to go over it in a practical manner. So when we talk about the substance use disorders in the DSM, they're always either use disorder, like alcohol use disorder, caffeine use disorder, and then intoxication, alcohol withdrawal, or alcohol induced psychotic disorder. Parang ganun. Okay, that's how they combine the terminology. And in ICD, it's not use disorder. They don't use the term use disorder, but abuse and dependence. Okay, so both of these abuse and this dependence have been combined into use disorder. And then there's intoxication, withdrawal, and like the other diagnosis. So we'll start with alcohol-related disorders. So here are some examples of the stuff that you drink, makes you happy, perhaps. Okay, and which ones are your go-to alcohol drinks? Okay, so sige nga, like magbigay ng mga generic ng alak. Ano ba naisip nyo? Magbigay ng mga brand ng beer that you know. What do you think is a top-selling beer brand worldwide? Of course, like I'm not talking to anybody. This is like a bummer. But to answer that question, the top-selling beer in the world is Coors. Okay? O yung Budweiser nyo, medyo mababa. No, but I guess this is because of like the number of people living in the vicinity where that is sold. All right. Magbigay ng mga Pinoy slangs associated with alak. When you say weng-weng, do you know what that is? Or you research that, okay? What does weng-weng mean in terms of like a person who likes to drink alcohol? But that pertains to a person who drinks. An adjective for that person. But like these are like some of the Filipino slangs for alcohol. Why is this useful information? Because when you talk to the people in the outpatient, in the clinics, then you have to know about these things. Kapag hindi nyo alam, they're talking about MP or empoy, you don't know that they're talking about emperador. Diba? Okay, so for years, alcohol has been a part of social gatherings, celebrations, and rituals. Addiction to alcohol is more of a problem today than it has ever been in the past. Unlike a century ago, we are now more aware of the serious complications it can cause. So, like, why do we drink? Apparently, these are the reasons, right? We also drink perhaps so that like slowly the person that we're on a date with becomes more and more attractive the more and more we drink. Okay, so history of the most primitive intoxicant. Okay, so our natives already drank palm wine when Magellan arrived in the Philippines. Who is this? Dionysius. Okay, if you don't know Dionysius, research it. Ancient warnings. Okay, regarding alcohol. So anong klase ng alcohol ang pinakakaraniwan na laman ng mga alcoholic beverages? What's the answer to that? So find out. Okay, maybe I'll ask it on your test. Okay, so we approach it now in a biopsychosocial manner. Now we're talking about the reasons or the reasons why people drink. Okay, biological. Alcohol in the brain. So alcohol is has an overall depressant effect. A downer siya. And these neurotransmitters are involved. Okay, what's the effect of alcohol in the brain? Okay, so yeah, no. This is in terms of BAC. Okay, so what's the legal level of alcohol for a driver here in the Philippines? I forgot. Alcohol in genes. There's a 3 to 4-fold increase risk for close relative with alcohol problems. The rate increases with the number of alcoholic relatives, severity of illnesses, and closeness of genetic relationship. So we're still talking about the biological aspect of alcohol and alcoholism. Okay, so 10% of the alcohol is absorbed in the stomach. The remainder is absorbed in the small intestine. It's absorbed in the stomach and can reach the brain in 1 minute. The peak blood concentrations in 30 to 90 minutes and faster on an empty stomach. That's why they tell you like eat fatty food or like you should be drinking on a full stomach kasi pag wala, mabilis ka malasing. Okay? Kasi mabilis pa-absorb pagka empty. Right? So fast drinking, faster time to peak, slower peak. Higher proof, faster absorption. Okay, this is how alcohol is metabolized, and the BAC levels 0.8 pala, 0.08 considered DUI positive. Okay, then the consequent effects. How about the psychological aspect? We're going through it fast because we have a lot of stuff to cover. Okay, psychological factors. Alcohol supposedly reduces anxiety and other mental health symptoms, makes you more confident, helps deal with the punitive superego, and then oral fixation versus oral regression. What's that? They say like when you're fixated during your oral stage, well, that's after your, that's the first stage, okay? Just psychosexual stages de Freud, no? When you're born. So either you're overly rewarded or deprived, hinahanap mo yung more often overly rewarded. You look for that as a way of comforting yourself. Then ganun din yung mangyayari sa iyo in your adulthood. No? When you're stressed, when you want comfort, it's like oral things like food and alcohol or smoking that would comfort you if you're fixated at that stage. Okay? And behavioral reinforcement. Maybe may kinalaman dun yung next factor, yung social. No? So, yung group or peer pressure or yung social attitudes to drinking. So if you see like it's something that's an activity that you and your friends do to parang get together, di ma-reinforce siya. You do it again and again para lang to keep being with your friends, no? Paano ba naman tayo makapag-avoid? Kasi like look at San Miguel Beer's advertisements in the past, no? So sarap mag-beer, sarap ng samahan, promotes unity, kahit kailan magkaibigan, no? So it programs you, it influences you how you think, no? That if you drink, then it's like something that promotes unity among friends. Hindi rin naman kahit kailan magkaibigan. Hindi rin naman exclusively just because you drink, right? So and then like how can you avoid drinking if you're like encouraged ka by like these kinds of images, no? And if that's not your drift, yan din. Sino ba naman ang hindi mapapainom? Pagka nakita mo yung ganun. Di syempre, parang gusto kong inumin yan. Okay, so summary. All right, so when we're talking about alcoholism, so there's the influence of genes is 60% and like the environment is 40%. Okay. So the trajectory, the clinical progression of alcohol use disorders is like this. So umpisa, it's more of the environment, no? And then later on, dependence na siya. It's more of the pharmacologic effects of the ethanol na yung nagko-continue ng symptoms. No? So we have to do something before it becomes a problem. Okay, so what are the different patterns of drinking? There's occasional drinking, moderate drinking, heavy drinking, and binge drinking. So what's considered as moderate drinking? It's 2 drinks for a day for men and a drink a day for women. Okay. if you drink like a man, you might end up looking like one. Okay, so but like what's a drink? So what do you consider as a drink? Kasi so like we say 1 drink a day for women. What's a drink? So it's a shot of hard. That's a drink. So like if you're a woman, you could tolerate 1 shot a day. Okay? So if sabi dalawa daw, two drinks if it's a man. So 2 shots lang dapat. Naku, nakailang shots ba kayo? Sobra na yata yung ininom niyo. Okay? So 1 can or 1 bottle of beer, 1 glass of wine. That's a drink. Okay? So how about you guys? O baka ganito gawin nyo. 1 drink pag women. Pero but your glass is like as big as this. A big ass glass. It's, oh, I have like I'm allowed 2 drinks per day because of I'm a man. So this is like your drink. Okay, so what's considered heavy or high risk drinking? In men, more than 14 drinks in a week or more than 4 drinks on a day. In women, more than 7 drinks in a week and more than 3 drinks on a day. Binge drinking is defined as a pattern of drinking alcohol that brings your BAC to 0.8 gram percent or above. For typical adults, 5 or more drinks in male or 4 or more drinks in female in 2 hours. Okay, that's the definition. So do you do this? Do you binge drink? Why do we need to talk about alcoholism? Okay, because we could die. Okay? It shortens our lifespan, and intoxication can cause these symptoms. Okay? That's before it becomes a problem. How about like when it's already a problem? When it becomes a problem, right? Dito na yon. Dito na yon. Dependence probably. Pwede rin harmful use. Hindi pa. It becomes a problem dito na yon. Ito usually yung intervention that we do. No? Self-change, brief counseling, behavioral and medication therapy. But we won't talk much about the intervention, no? Because there's another lecture that would tackle intervention for substance use. I'm not sure if I'm the one going to lecture about it as well. Okay, so in the DSM, these are the diagnosis under the alcohol use disorder group. Alcohol use disorder, alcohol intoxication, alcohol withdrawal. And in terms of the ICD, yan, meron sila alcohol, harmful use of alcohol. Wala yun sa DSM. Maybe it could fall under mild alcohol use disorder, mild severity. Pero iba yung iba yung definition sa harmful use eh. So characteristics of an addiction, there's a pattern, okay? Matagal na siya nangyayari. There's tolerance, no? Is padami ng padami, patagal ng patagal. There's dependence, there's withdrawal. Okay? So DSM definition of a use disorder. This is in general not only applicable for alcohol, no? So think about this when we talk about the other disorders as well. So there's a problematic pattern of alcohol use or whatever it is of meth or what you call this, inhalant or hallucinogen, leading to clinically significant impairment or distress within a 12-month period. And then larger amounts are taken over a long period than intended. There's a persistent desire or unsuccessful effort to cut down. There's a great deal of time spent to obtain whatever the substance is. Craving is a new symptom in DSM-5. No? Craving. Sometimes when individuals are already in remission, they're allowed to have craving. It doesn't mean that may relapse na sila pag may craving. The DSM acknowledges that. Okay? Basta wala lang yung ibang symptoms. The use results to failure to fulfill major roles or obligations. The use, despite recurrent social interpersonal problems, they still use despite that. They give up important social occupation and or recreational activities. They use the substance in situations where it's physically hazardous, like for example, driving. Alam nila na mag-drive sila, pero inom pa rin sila, no? So imagine like, I don't know if nabalitaan nyo yung like soldiers who had like met an accident in EDSA in the bus lane, 4 soldiers, Air Force men, I think. No, so they went to a party, they drink, they know that it's dangerous to drive even if they are intoxicated, but they still drove. Then they're like, all of them died, I think. No, so continued use despite knowledge of physical or psychological problems that's caused by the substance, whatever it is. There's tolerance and withdrawal, right? How about the definition of harmful use in based on the ICD? Use of the substance, that's the substance that is causing damage to health. The damage may be physical or mental. The harmful if dependence is present, hindi na siya harmful use. Dependence na yun, syempre. No? So, acute intoxication is not in itself sufficient evidence of damage to health required for coding of harmful use. Kasi pagka minsan uminom lang ng isang beses pero hindi naman siya lasenggo, na intoxicate siya, yun yung intoxication. No? So, a dependent could be intoxicated. A person with no dependence could also be intoxicated. So, it's not automatically kasama sa isa't isa. Okay, so this is definition of dependence, 3 or more, okay, based on ICD definition. How about the effects? What are the biopsychosocial effects of alcohol? Biological. So ito mga, what could happen? Conditions that could happen, of course, like very high on that list would be liver cirrhosis because of alcohol use disorder. How about comorbid psychological psychiatric disorders that could happen? Ito. Tsaka yung odds risk ratio. What does odds risk ratio mean? So there's a 2.6% more chance of you having anxiety disorder if you have alcohol use disorder than like the individuals who are not alcoholic. Gets? Okay, so what does drug dependence? Mataas, di ba? There's a 36.9 times more chance of you having other polysubstance, you use other substances as well. Okay? Social. Okay? So, ano ba yung what are the social effects of alcohol use disorder? Right? They could have like deaths. You could do these things, no? Hopefully not be involved in crime. What does the Philippine data tell us? Medyo obsolete na yung data natin, no? We need new research on this, no? Basahin nyo na lang yan. Who are the people who are more likely to drink? So, people not living with their parents. Are you living in a dorm? Parents approves drinking frequently in social gatherings, enjoys going up to parties, bars, events, do not take part in sports. Oh, wow. Okay, so review. How about the part that what we could do? No? We will skip this. We will skip this. Okay? Oops. Let's go back a while. Let's take a break for like a few seconds. I'm just gonna scratch my nose and drink some coffee. Okay. We move on to stimulant-related disorders. So when we talk about stimulants, the most common example would be meth or amphetamine. Okay. So the most common form here is crystal meth or shabu. Okay. History of meth. You just read this. I'm going to send you the slides. Okay. Why meth is very common here? So base is illegal, easy to make, large market, many IV users, law enforcement before was poor. There's child welfare. There's a lot of very porous country. Okay, it could be like introduced like we have a very large coastline. Abuse pattern for meth. Okay. What are the effects of methamphetamine? Right. First, we discussed the chemistry and the physical properties of meth. Okay. It's produced through the chemical reduction of pseudoephedrine and ephedrine. Okay? It's an N-methyl derivative of amphetamine and falls under the phenylethylamine class of psychostimulants along with amphetamine, ephedrine, pseudoephedrine, and MDMA. Methylene dioxymethamphetamine, okay, or ecstasy. More rapid onset of action due to the added N-methyl group, and it's resistant to degradation by your MAO, monoamine oxidases. Okay, it consists of a mixture of D and L stereoisomers, but the D stereoisomer is 10 times more potent in causing dopamine transporter disruption and thus inhibiting dopamine reuptake. Okay? Dopamine reuptake net effect is increased dopamine in the synaptic cleft, therefore producing more euphoria. Okay? And pwedeng mag-cause ng psychosis. The L stereoisomer has little CNS effect. Okay? So what we call crystal meth or shabu is chemically D-methamphetamine hydrochloride. Okay? So what's the meth pharmacokinetics? No? So tira ng meth, there's a rush. Okay? Most common form of intake, snorted. So, yan. Pwede rin inhaled, fusing like a device. Okay, so, and then there's an extended high when the person is overstimulated and has rapid flights of ideas or speech. And then a crash. If you don't like repeat, some people like pagkatapos ito, before mag-crash, alam na nila, they take it again, rush ulit. So, yun a cycle. Okay, but like if they crash, when they experience this, ang kasunod, hangover and withdrawal. Okay, the meth penetrates the blood-brain barrier easily. Half-life is 12 hours, more or less, and metabolized through 3 different routes. Okay, so demethylation, aromatic hydroxylation, and beta hydroxylation, and is mostly excreted in the urine. So we test urine. How many days will you be positive in urine test? 4 days. Okay, kaya tinanggal na yung driver's test because it's useless. Because when after we just don't take for 4 days, then you'll be negative. Then they have a test, negative na sila, pero after that, they could still take again. So the test has to be random, or you could take other samples from the hair para mas matagal yung anong tawag dito, yung the time that you could detect the meth. Okay? So meth is an indirect agonist for dopamine, norepinephrine, and serotonin. High affinity sa norepinephrine and dopamine receptors with the mechanisms of blocking monoamine reuptake, inhibiting vesicular storage, inhibiting malmetabolism, and reverses reuptake. Ang net effect niyan, combined net effect is increased dopamine in the synaptic cleft. Okay? Kasi the monoamine degrades the what they call that, the dopamine. Okay? In terms of tolerance and withdrawal, there's a high abuse potential. Physical and psychological dependence. I'm looking here because I'm looking at my other screen for reading a lecture. Okay. Withdrawal, there's physically mild to moderate withdrawal, and the symptoms are hunger, fatigue, anxiety, irritability, depression, panic attacks, and dysphoric syndrome. Okay. The dysphoric syndrome occurs 1 to 5 days after the crash, characterized by decreased activity and motivation, intense boredom, and anhedonia, and may last for 1 to 10 weeks. So that 1 to 10 weeks withdrawal, dysphoria, is the time period when they're like at risk of taking it again, so that they should be like isolated and like in a controlled environment. There's anhedonia from biogenic amine depletion and intense craving during this time. Okay. Okay, so when a person is intoxicated, it's more of dopamine and serotonin. When there's withdrawal, there's also norepinephrine that's involved. Okay, so these are the neurotransmitters, and these are the clinical symptoms that are produced by the effect of meth on these pathways. Okay, gets. These are the most frequently reported withdrawal symptoms. Basahin na lang. And the public health burden of meth use. The treatment for meth, the interventions that we do for meth use disorders, we will discuss it in another lecture. So in terms of the DSM, the diagnosis there would be stimulant use disorder, stimulant intoxication, and stimulant withdrawal. Okay, the criteria, you just review it in the DSM. That's your assignment. Review the criteria. But it's similar from what I've discussed before. Nag-iiba lang yung, ini-insert lang nila yung word na stimulant. Okay? O kaya, kasi hindi meth eh. Hindi meth ang ginagamit. Stimulant-related use disorder or stimulant use disorder. General yung term. But you could actually write meth if you're able to identify specifically the substance that's being abused. Oh, ito, we could relate to all of us could relate to this. Caffeine-related disorders. Okay? Caffeine is a stimulant as well. Not of the order of magnitude of like meth, of course, but it's a stimulant. And the natural sources for this chemical is coffee beans, tea leaves, and cola nuts. Okay? So when we talk about the pharmacology of caffeine, it's absorbed from our GI tract 30 to 60 minutes after ingestion. It begins in the stomach, but most of the absorption happens in the small intestines. The average half-life is 4 hours. It's metabolized by the liver, and it's metabolized into these metabolites. These are the, when it breaks down, it turns into this. Most of it turns into paraxanthine, 84%, theobromine, and theophylline, 4%. So 95% of these metabolites are eliminated in the urine, 2.5 in the feces, the rest are the body fluids, including your sweat. So you sweat out coffee. So if you drink too much coffee, you'll smell like coffee probably. Okay, so 2% is excreted unchanged. So here's a summary of that. So we ingest it, it's absorbed in the stomach and the small intestine. Okay. It could go to the brain. It binds mostly to our adenosine receptors. Caffeine binds to our adenosine receptors. These are affected as well, but like the most of it, like almost all of it binds to adenosine receptors. Okay, it crosses the breast milk. If you breastfeed, it crosses the what do you call it? It goes to the breast milk. Okay, so you have to, for the nursing mothers, you have to, like, if you don't want your baby also drinking coffee, you have to avoid that. Okay, so it also crosses the placenta. All right. And also caffeine is reabsorbed at the kidney. Okay. So when it's metabolized by the liver, as I've said earlier, it turns into these substances. Okay. And then these are the effects of these substances. So paraxanthine increases lipolysis. Wow, nakatunaw siya ng taba, no? Sana lang nakakapayat talaga, like pag uminom ka lang ng kape, payat, hindi laman. And then theobromine increases your urine volume. This is the diuretic part of the coffee. Theophylline relaxes smooth muscles. Kaya parang you have good digestion after it. Like maybe yun na nga din. It helps with the naiihi kayo kasi nag-relax din yung smooth muscles ng inyong sphincter. Okay? Why do we take caffeine? It increases our alertness, provides a boost of energy, increases well-being, happiness, and sociability. And it's sometimes prescribed as in the pure form as medication to battle tiredness or drowsiness, or like narcolepsy perhaps. How about what if like you have too much coffee, you experience these symptoms? Okay. What if like you have withdrawal symptoms from coffee? Like after 12 to 14 hours of like sudden you suddenly stop taking coffee from like very high caffeine intake, you experience these symptoms. Now, what do we consider as moderate consumption of coffee? Mag-alaman na tayo, no? 400 milligrams per day. That's moderate. So now we examine examples like, do you take Mountain Dew? But this is Kickstart, the one that is like higher caffeine than normal. Each is has 90 milligram of caffeine in it. So one can is considered one serving. So ilan yung moderate intake? 400. So apat o to almost 5 of these na pwede pa, moderate pa, okay? Who takes Monster energy drink? Okay, this is not the green one, the black and green one, no? This is Ultra. The Ultra has higher. I think like the green one has 130 lang. Pero ito 160 milligrams per. So dalawa pa lang, tama ba? Dalawa pa lang, almost ano na yun, considered na limit na dapat yun. Okay? O ito, like local setting, Cobra. Cobra has 134 milligrams of caffeine in each in one serving in like this ilan ba to? 12 fluid ounce bottle or something. Okay, so ganun din, halos dalawa, almost tatlo. Eh baka iba naka-driver ng jeep, baka naka-ilang Cobra na Red Bull has 133.5. O yung Red Bull pa pala ang konti. O baka hindi makarelate yung iba, this one you are able to relate. No? Sa Starbucks. This is for Grande. We'll take Grande as our what do you call that? Template. Okay, I usually have like an Americano. Americano has 3 shots. Oh yeah, 75 milligram each shot of Starbucks espresso, 75 milligram of caffeine. So Americano usually is 3 shots. So pag gusto mo pang, if you're driving, you want like, I want to have an extra shot. So 4 shots, extra shot Americano Grande. So ilan na yun, di ba? That's almost the normal consumption for the whole day. Oh, look at like blonde roast. Here, blonde roast, 360 milligram caffeine content ang blonde roast Grande. So that's almost your limit for the day if you're a supposed moderate caffeine drinker, no? Again, 400 milligram per day, moderate consumption. So now, you have to reflect, how much caffeine are you drinking, no? If you're just drinking regular brewed coffee, each drink is 95 milligrams. 95 milligram regular brewed coffee. If you're drinking coffee house coffee yan. If you're drinking tea, black tea, that's just 47 lang yun. Medyo madaming pwedeng tsaa yung inumin mo. Well, if it's green tea, konti lang. Green tea na lang tayo, no? Okay? Is this brand here? Pero nakita ko to 5 hour energy shot. It's a energy drink as well. No? Taas o 10-hour energy shot, 422. Oh, ito na naman. Pre-workout. Pre-workout has a lot of caffeine, okay? How much caffeine do you think is in pre-workout? Who goes to the gym? So each scoop has, depending on the brand, 150 to 300 milligram of caffeine in it. So, baka naman nag-pre-workout kayo, one scoop, tapos baka naman, tapos nagkape pa kayo and all. So, lampas na, no? What question, is decaf zero caffeine? No. Okay, it has lesser, but it's not zero. Like if you go back there, it's 25 milligrams. Where did I put that? Oh, decaf. The grande, 25 milligrams of caffeine. So it has lesser caffeine, but it's not zero. Okay. So let's talk about the toxicology of caffeine. So toxic symptoms start at 15 milligrams per liter. Okay, but we're talking about blood concentration here, not the actual milligram of content of caffeine intake. Kasi we metabolize it. But like when you take the blood concentration of it, this is where the blood concentration level where we could observe toxic symptoms. The toxic dose is 15 milligrams per liter, and the lethal dose is 80 milligrams per liter blood concentration. Okay. There's no diagnosis in DSM na caffeine use disorder. Okay? Wala. Luckily. Walang caffeine use disorder. But there's caffeine intoxication and caffeine withdrawal with the following symptoms. But it defines a recent consumption of caffeine as a high dose in excess of 250 milligrams. Pero actually, di ba sabi niya 400? But that's in a day. Okay? Pero individuals could be intoxicated with just 250 by definition of the DSM. Okay, these are the symptoms. And then caffeine withdrawal, defined as abrupt cessation or reduction, sudden reduction in caffeine use followed within 24 hours of the following symptoms. Okay, intervention, we don't talk about it on this lecture, on another lecture. Okay. So we talk now about chonky, cannabis or chonky. I will not ask you anymore who's tried or like does chonky. Okay, history of cannabis. Most of the circulating strain by the 2000s is called sensimilia. All right, and like more recent research focus on like producing more potent strains. There's two big groups, okay, with different effects. The indica has higher cannabidiol content. Okay, the sativa has higher THC content. So this is the preferred choice. Kasi ito yung psychoactive compound, THC. Let's go back to the history, okay? So the compounds were isolated, discovered in the late 1960s, okay? Live plant, the cannabinoids are stored as cannabinoid acids. But when you dry it and store it and heat it, the acids decarboxylize into CBD or THC. Okay? Nagtatransform sila. Pharmacology of cannabinoids. So if it's inhaled, it's nearly absorbed. Everything is nearly absorbed. If it's ingested, only 20 to 30% is absorbed. Okay, there is a significant first pass effect. And therefore, if you ingest it, brownies or edibles, there's delayed onset but prolonged effect because of the continued slow absorption in the gut. And the paikot-ikot siya, pwede siya ma-reabsorb. Rapidly distributed once absorbed, is extremely lipid soluble, stored in fat, and reaches peak concentration in 4 to 5 days and slowly released backwards. So if you're fat, and you ingest edibles, mas matagal mag-linger yung effect. Kasi may store sa inyong fat and then slowly released. Tissue elimination half-life is 7 days. complete elimination may take up to 30 days. You'll be positive for THC sa urine for like how many days? Or weeks? 2 weeks, okay? 2 weeks after, hanggang 2 weeks. After 2 weeks, tsaka pa lang kayo mag-negative sa urine. It's metabolized by the liver. The major metabolite is called 11-hydroxy-THC, which is actually more potent than THC. Okay, so the lingering metabolite is like more potent and has more effect. And there are other 20 more metabolites. The metabolites are partly excreted in the urine and most of it is reabsorbed. Okay, therefore, like that's why it's so long in the system. Okay. So where does THC and go in the brain? It attaches to the cannabinoid receptors. There's CB1 and CB2 receptors, but the more relevant one is CB1. It's a G protein coupled receptor, and its presence in the brain, there's a lot of it in the basal ganglia, hippocampi, and the cerebellum. It's not found in the brainstem, and that's consistent with cannabis. Oops. And it's sorry, I just like had the running moment that I didn't press record and I checked if it's recording properly. It's not found in the brainstem, consistent with cannabis' minimal effects on respiratory and cardiac functions. Okay. The net effect is an inhibitory action on release of excitatory and inhibitory dopaminergic GABA, glutamatergic, serotonergic, and noradrenergic and acetylcholine receptors. That's why it's a downer. Okay. It inhibits excitatory and it inhibits dopamine and which is like these are excitatory what they call this neurotransmitters. Okay, so if you inhibit the excitatory, you net effect lahat inhibit, so downer siya. CB2 is mostly present in like other places. It doesn't have much anything to do with what they call this, the effects of cannabis. What's anandamide? This is the natural, this is the endogenous neurochemical that attaches to the cannabinoid receptors. So actually, the receptors should be called anandamide receptor. But since like we know that it was named after the substance that we ingested first, that we know attaches to it. But actually, conceptually, we know that there's probably an endogenous substance that an analog of THC. Kasi we won't have a receptor for it kung wala naman tayong substance that attaches to it. And that's called anandamide. So this is how anandamide appears. This is THC. THC mimics anandamide and binds with that receptors that's supposedly named for it, not for the okay. What are the positive effects of cannabis? Okay, these are the positive quote unquote positive effects of cannabis. We talk about a little about medical marijuana. So these are the FDA approved synthetic versions of THC. Dronabinol, which is approved for AIDS and for chemotherapy. Nabilone, also same function, antiemetic for chemotherapy. And Nabiximols Sativex, which is a spray for neuropathic pain. Okay? And also could function for MS. How about negative effects? These are the symptoms. And at higher doses still, these are the symptoms. Okay, so you review criteria for the DSM criteria for cannabis use disorder, cannabis intoxication, and cannabis withdrawal in the DSM. Going to ask you about those things as well in your exam, okay? Are we halfway there yet? Oh, we're more than halfway. Okay, that's good. So we talk about hallucinogen-related disorders. What's this plant? This is called talampunay or kalampunay. Okay? This is the most common hallucinogen we encounter here because we don't have shrooms here. LSD meron, but like, hindi siya palasak. Okay? So, hallucinogens are natural or synthetic drugs that alter sensory processing in the brain, causing perceptual disturbances or hallucinations, changes in thought processing, and depersonalization. Psychedelic drugs include LSD, mescaline, psilocybin, club drugs, and raves. Okay, and like talampunay, it's genus Datura. We have this in our farming silang. Okay. So LSD is D-lysergic acid diethylamide. Okay, it's from a parasitic fungus that grows on rye. Okay, not gonna ask again, like who has tried LSD? Okay, so usually like it's a piece of paper that you put on your tongue, then like start there. Trip. Okay, pwede rin ipatak. Pharmacology of LSD. I'm tired. Okay, they act on serotonin receptors on the frontal cortex and limbic system. Okay, disrupting the sorting process and flooding of sensation and perception. Okay, what are the other common hallucinogens? Would be shrooms and mescaline. These are the physical effects of taking hallucinogens. Okay. So should we take it in aid of self-reflection? For making the unconscious conscious? So yung mga sayangan at saka mga individuals who experience ano mo tawag dito? Parang mystical spiritual experience, baka naka-hallucinogen. Okay? So these are the psychological effects. How can you tell if somebody's on a hallucinogen trip? Ayan. Oh, this one. Dilated pupils. Tingnan nga natin. Skin is warm and clammy to the touch, excessive perspiration, unnatural body odor, disturbance of sight, hearing, and touch, distortion of self-image, warped perception. Have you seen Doctor Strange, the first movie? So para siyang nag-LSD trip doon actually, no? Nung para siyang nung pinush siya ni the Ancient One, like nagfo-fall siya na gano'n, yung mga colors, gano'n. That's like an LSD trip. Ganun yung na-experience ng mga naka-hallucinogen. Okay, so review again, the diagnostic criteria for hallucinogen use disorder, hallucinogen intoxication, and hallucinogen withdrawal. Now we talk about inhalant-related disorders. Okay, kilala nyo ba yung mga yan? You see that those sa mga tabi-tabi dyan sa ano? I'm sure his name is Vincent, this one. you know why I thought that? Okay? So mga rugby boys. Pero paano yung ano? Of course, like these are not like don't have toluene in it, but like some of the pentel pens that are not for kids have addictive substances in it, kaya mabango sila. No? O baka ganito na itsura nyo rin. Hinihit-hit nyo yung pentel pen or yung whiteboard marker. Kung nababanguhan kayo doon dahil doon sa mga solvents yun na nandun. Okay? It's like from one type of inhalants called solvents. Yun din yung rugby. It's a solvent. So, breathable chemical vapors that produces mind-altering effects. Okay? So, alin dyan? Ako yung, what you call this? Like, the one that you used to bind the pipe, water pipe. That's also a solvent. Okay? Also hairspray, paint thinner. Kaya mabango din yung paint thinner eh. Tsaka iba pati gasolina tinitira na rin, no? Yun. Okay, so ito laughing gas, nitrous oxide. Okay, so we use inhalants through sniffing, huffing, or bagging. Grabe, oh. Application of paper and then the bag is held over the face. Nilalagay nila yung ulo nila sa loob ng bag. Oh, I haven't seen that one yet. Okay, so it's highly lipid soluble. It easily crosses the alveolar membrane and the blood-brain barrier. Okay, and it avoids first pass hepatic metabolism, accumulates in brain tissue. The exact mechanism of action is unknown, but it's theorized to potentiate the effects of GABA and dopamine. Dopamine, as like we've discussed much earlier into this lecture, is involved in the reward system. So that's why what gives you that euphoric feeling. Okay, so the inhaled concentration depends on the route of administration. Okay, elimination occurs primarily through the lungs as well. So these are the effects of the inhalants and on these following brain structures. Okay, effect of acute intoxication of inhalants, a sense of intoxication similar to alcohol or marijuana, sensation of floating, spinning, blank. I think like the kids that do this on the street do that so that they won't feel hunger. Okay. Also could produce hallucinations, and chronic use of it can cause withdrawal symptoms, which could lead to delirium tremens, similar to alcohol. Nagkakaroon ng seizures during withdrawal. Okay? Effects of inhalant, and it could cause you to suddenly die, sudden sniffing death. Okay, could have arrhythmias and seizures from it. So pulmonary effects. Okay, how can you tell if an individual is, of course, like if you see them like doing it on the street, no? But aside from that, there's recurrent epistaxis, rhinorrhea, yeah, watery eyes, glue sniffers rash on their face. Amoy ano na, they smell like pentel pen din. Yung breath nila, amoy pentel pen. So just review the characteristics, the diagnostic criteria for this inhalant use disorders, okay? Are we there yet? Oh, I think like this is the last part. So if I don't know if you've seen like House, the series House. He was addicted to opioid, no? To painkillers. No? So I think it was oxycontin, oxycodone. That's an opioid pain kasi he was having a lot of pain. Kaya di ba he limped, meron siyang problema sa leg. It's painful, so he takes a lot of painkillers. He got addicted to it. Okay, so morphine, oxycontin, oxymorphone. Okay. We have to distinguish between opiates, which are the natural ones, and opioids. Okay, so that includes synthetic compounds that are not really opiates but mimic the action of opiates. So we also classify opioids by their activity in the opioid receptors, okay, mu receptors that okay, because they have different functions. Mu receptors are endogenously activated by beta endorphins, and this is largely responsible for the pain relieving effects of opioid compounds, the euphoria, the cough suppression, the respiratory depression, the pupillary constriction, and constipation. The delta receptors, which is endogenously activated by enkephalines, the natural substance that activates it, is associated with the anxiolytic and antidepressant-like effects of opioids. Okay, but it's the receptor responsible for its like addicting properties. Okay, how about the kappa receptors? endogenously activated by dynorphin. Okay, also associated with analgesia, right? But also produces a distinct profile effect, most notably pro-depressant and aversive effect. A kappa agonism reduces dopamine release in the nucleus accumbens, while kappa agonists can be clinically useful as antagonists of abused psychostimulants. All right. An example of this is the antidepressant buprenorphine. Okay, kappa antagonists can be clinically useful to counteract dysphoria of cocaine withdrawal. Okay. The NOP receptors are endogenously activated by nociceptin. They're considered part of the opioid family because of its structure, but they represent a separate group in terms of pharmacology and effect. Because baliktad yung effect niya. Hyperalgesia yung pagka na-stimulate siya. No? These are the more commonly encountered opiates substances. And their the pharmacology of them. Okay, and the duration of action, duration of effect, onset of withdrawal, and duration of withdrawal. Okay. Review the diagnostic criteria of opioid use disorders. Tobacco-related disorders, last part of our lecture. For the non-substance addictions, I will send you a handout on that na lang. Okay. The only non-substance addiction in the DSM is pathologic gambling. The other addictions could all actually fall into impulse control disorders. Right? Like for example, because like the DSM doesn't contain an internet addiction yet or cyber addiction. But in the ICD, the upcoming ICD-11, it's already contained. There's a diagnosis there for internet addiction. Internet addiction, internet use disorder, perhaps. But in the DSM, it's not yet contained. Even in the new DSM-5TR, there's only pathologic gambling. So there could be shopping addiction, there could be sex addiction that could fall into impulse control disorders. So technically, we only need to discuss pathologic gambling, but like we'll touch on a little bit of the other non-substance addictions, but I'll just send you like a handout of it. Okay. Last topic, tobacco-related disorders. Tobacco-related disorders. So nicotine comes from this guy. It was named after him. He didn't discover it, but he brought it to France. Okay, so this is Jean-Nicot de Villemain. I don't know if I said it correctly. He's a French diplomat. And Carolus Linnaeus, the Swedish, am I making a mistake? The Swedish guy who named a lot of he invented the nomenclature. Okay, the nomenclature and the naming of the scientific names of the flora and fauna. He named the tobacco plant after this guy, Nicotiana tabacum. Okay, he introduced it into he brought it from Portugal to France, presented it to the French king. The French believed that smoking it would protect against illness, particularly the plague. That's why like everybody like started smoking, got addicted from it. Okay. Nicotine is the main psychoactive ingredient in cigarette. It was first isolated by these guys. Okay, it crosses the blood-brain barrier and binds to your nicotinic acetylcholine receptors. So we have muscarinic and this like especially even if the receptors was like nadamay na named after the guy. And there's alpha-4 and beta-2 subunits of that receptor that's responsible for 90% high affinity binding to brain. Okay, the alpha-4 subunit is responsible for the nicotine sensitivity. The beta-2 subunit is responsible for the dopamine release and the behavioral effects of nicotine. So it's rapidly absorbed if it's inhaled and moved to the brain in seconds. It's also absorbed to the membranes by like if you chew nicotine. Okay, nicotine metabolized to cotinine by the liver enzyme CYP826. And the rate of metabolism is faster in women than in men. Okay? At low doses, nicotine acts like a stimulant, producing arousal, increased heart rate, and blood pressure. And at high doses, it produces bradycardia, hypotension, depressed mental state. Oh, I finished. We're not going to discuss what interventions we do for tobacco-related disorders. Again, that's for another lecture. This is have been like 184 slides. Thank you very much for listening. I hope we get to see each other live in the future in the classroom. This is Dr. Alipio. Have a good rest of the day and good luck in your exams.